EHRA CardioTalk. Keep the rhythm. The EHRA podcast.
Welcome everybody to EHRA CardioTalk, Keep the Rhythm, the EHRA podcast. This podcast provides educational insights into current topics in cardiac electrophysiology and talks to established and well-respected experts in EP from all over the world. My name is David Duncker. I'm the head of the Hanover Heart Rhythm Center in Hanover, Germany, and I'm the chair of the EHRA Digital and E-Communication Committee. And the episode today is about cardioneuroablation, and my guest today is Professor Tolga Aksu. He's a cardiologist and electrophysiologist at the University Hospital in Istanbul in Turkey, where he is the director of the clinical electrophysiology. His special interest areas are ablation of AF, cardiac and autonomic nervous system, and neuromodulation of clinical arrhythmias. And he's actually the chair of an upcoming EHRA, HRS, LAHRS, APHRS document on cardioneuroablation that will be published this year. And I'm very happy that we can discuss this. Welcome, Tolga.
Thank you so much, David, for kind invitation and presentation.
Yeah, I think cardioneuroablation is a uncommon topic for the electrophysiologist, Tolga. Probably we should start with the importance of the autonomic nervous system for clinical bradyarrhythmias before we discuss the main topic. Can you help us?
Actually, I think this is one of the most important questions because now we clearly know that, especially in patients with vasovagal syncope, and enhanced autonomic or parasympathetic tonus is the main contributor of occurrence of syncope episodes. And we also know that in some patients with sinus bradycardia or asystole, or in patients with paroxysmal AV block, the main reason is an imbalance between parasympathetic and sympathetic system. So we also know that in some patients with atrial fibrillation, and maybe we can call as vagal-mediated atrial fibrillation, the main reason is a vagal overactivity. So I think that autonomic nervous system is very important for clinical arrhythmias.
Yeah, and then what is cardioneuroablation then? What do we need to know about that?
So, cardioneuroablation, firstly defined by Professor Pachon from Brazil in 2005. Actually, we can say that endocardial ablation of parasympathetic neuronal fibers and parasympathetic neuronal bodies, because according to our anatomical knowledge, we know that parasympathetic neuronal bodies located in left and right atrium in epicardial area. So if we can find this area or this clustering site of epicardial ganglia, we can ablate parasympathetic system. So cardioneuroablation aims to ablate parasympathetic system.
And how do you actually do this? Can you explain this? Even if it's only a podcast, you can't show us videos, but what do you really do for this ablation?
So according to animal experiments, we actually imagine the possible localization of this epicardial ganglia, because we know that in some well-defined area in left and right atrium, we see clustering of epicardial ganglia, and this site is called as GP or ganglionated plexus. In human, usually there are 5 major and 2 minor GP sites, and without using any mapping technology, without using any additional equipment, just using a 3D mapping system, we can ablate great majority of this GP site, because we know that the great majority of GP is located in midline area between superior vena cava and right superior pulmonary vein, in interatrial septum area, and between lower part of left atrium and coronary sinus ostium.
And how can you find them? How do you do this?
So if we want to use some special equipment, for example, if we use high frequency stimulation, we can perform a high amplitude and high frequency stimulation in left or right atrium. And if we induce vagal response like sinus bradycardia, asystole, or high degree AV block, we can think that this area should be related to autonomic innervation site. So we can tag this site in 3D mapping system, and then we can ablate this area. And at the end of ablation, we can try to find there is no new vagal response in the same area. to say vagal denervation, or we can use fragmented electrogram. This is our current approach to define this area. Just checking fragmented electrogram site by changing some bandpass filter setting, we can define this area, but there is still no gold standard for GP mapping. This is one of the most important limitation of the cardioneuroablation.
Yeah, and maybe can you extend on this? What do you need for this procedure? Is it a special preparation or special devices or only special skills?
So I think that we should start from the anesthesia because, for example, if you want to use high frequency stimulation, you need to see vagal responses. But if you use some general anesthetic agent, it will completely change parasympathetic and sympathetic tone. So to see vagal response, we need parasympathetic overactivity. So if you use a sympathetic anesthetic agent, you cannot see any vagal responses. So the used anesthesia will completely change the procedural steps. So if you have a chance, I usually suggest to use mild sedation or moderate sedation for cardioneuroablation procedure to see vagal responses. But it is not easy to use mild sedation. For example, high frequency stimulation usually cause serious pain, and it's not easy to say the patient, please calm down. You can feel some pain. So it's a little bit difficult, but I think that now the most promising method for GP mapping, checking of electrogram, because some new 3D mapping system companies created some software to find these fragmented electrogram sites. I will not give the special names, but by using this fragmentation softwares, you can define some area. For example, in anterior wall of right superior pulmonary vein, in intraarterial septum area, and around coronary sinus ossuary. As I mentioned before, this area usually contains the great majority of epicardial ganglia. For some minor GP sites, we still don't know the best mapping strategy, but recently, Abbott created a new mapping software calculating the peak frequency. So I have a couple of cases, and we know that in GP area we usually see fragmented electrograms and high frequency electrograms. So by defining this fragmentation and high frequency, we can define our focused area during 3D mapping system or electrophysiological study.
And which patient would you consider for this type of ablation? So what are the indications for this?
So I think this is one of the maybe most important questions, because if we are talking about vasovagal syncope patient, I think that the indication should be similar with cardiac pacing. For example, you suggested lifestyle modification, physical counterpressure maneuvers, but there is still recurrent or severe syncope episodes. And by using tilt testing or implantable rip recorder, you demonstrated a clear cardio inhibitor component, and then you decided to implant cardiac pacemaker. I think that in that step, we can decide which procedure should be selected, pacing or cardioneuroablation. If the patient is younger than 40 years old, there is no randomized controlled trials demonstrating positive effect of cardiac pacing, and guidelines doesn't suggest cardiac pacing in this patient population. So if you look at the published data for cardioneuroablation, usually mean age is like 30 or 40 years old. So I think that the most important patient group should be younger than 40 years old. Between 40 and 60 years old, I think that we can still select cardioneuroablation if there is dominant cardioinhibitor response as a first option. But in patient older than 60 years old, it's not easy to differentiate structural involvement of sinoatrial node or atrioventricular conduction system. So maybe, and we also know that there are too many randomized controlled trials demonstrating positive effect of cardiac pacing. And I think that, or our document writing group believe that in patients older than 60 years old, cardiac pacing still should be the first option. But for AV block or sinus bradycardia cases, the most important problem, it is not easy to say vagally mediated AV block or vagally mediated sinus bradycardia, because in some patients, of course, for example, we are seeing some high degree AV block episodes, especially during evening times. But if you checked Holter or prolonged ECG monitoring, this patient usually have a little bit PR prolongation or some other clues of structural involvement of AV node. So if you want to use CNA in patient with AV block or sinus bradycardia, you should think about that. This is still a very, very experimental strategy, because there is only 2 published study for AV block, just cohort studies, and there is only 2 studies for sinus bradycardia patients. So we have no clear data to suggest CNA in this patient population.
Yeah, so still some areas of uncertainty, obviously, but especially for this clinical guidance is needed, and therefore your upcoming document is probably very important. Now, looking at the perspective, what will cardioneuroablation will be about in, let's say, 5 years? What will change and what is needed?
Thanks so much for this question. Now we are waiting a couple of sham control trials. You know that, for example, many years ago, there was some very positive studies for cardiac pacing. And then after 2 sham control trials, we found that there is a huge placebo effect for vasovagal syncope population. So, of course, according to our cohort studies, we see a very huge success rate after cardioneuroablation, but we still don't know the possible effect of placebo for this patient population. And we are now waiting for 2 or 3 sham control trials for vasovagal syncope patient. And after that, if we see the similar results after this sham control trials, I think that CNA will be mentioned in next syncope guideline. For AV block and sinus bradycardia patients, there are a couple of studies comparing CNA versus cardiac pacing. And after that, maybe in minority of the patient, in very, very selected patient population, we may use or we may suggest cardioneuroablation in patient with AV block and sinus bradycardia. And I'm very excited to see the results of these important studies.
Yeah, thank you very much, Tolga. We will keep an eye on these 3 indications: sinus bradycardia, AV block, and syncope. Thank you so much for sharing your thoughts on this exciting topic. And now we come to the second part of this podcast, where I will have some rapid fire questions for you. Are you ready?
Yes, please.
Heart to heart.
Okay, what's best at being an EP?
Actually, in high school, I liked math and physics too much. And I think that we have a chance to use these skills in EP. And I think this is very funny and the best part of to be an EP.
What's your favorite ablation procedure?
Certainly AFib ablation.
I thought cardioneuroablation.
Not yet.
Okay, what makes you laugh?
I think that if we are talking about the work, to find some new methods was the very funny and the most exciting part of to be an EP. But if we are talking about routine life, I like playing guitar, and I feel very, very emotional in that times.
After 4 hours of burning, what makes you continue?
I usually think about the previous 4 hours, and I say that I have to keep on in other ways. I will not do anything so far. So I am always trying to keep. Maybe sometimes I'm waiting 10 minutes and then turn back.
Very good. Okay, thank you, Tolga. The next part is the A or B game. Do you know it?
Yes, I know that.
Okay, then we can start right away.
A or B?
Coffee or tea?
Coffee.
Summer or winter?
Certainly winter.
ECG or PPG?
ECG.
RAO or LAO?
LAO.
Tucky or Bruddy?
Brady, of course.
Car or bike?
Car.
Pacemaker or ICD?
ICD.
Cryo or PFA?
I don't use PFA, but I would select PFA.
RVOT or LVOT?
For easy one, RVOT.
Surfing or hiking?
Surfing, certainly.
Single or double transeptal?
Single.
Review 1 or Review 2?
River 2.
Excellent. Thank you, Tolga. That was fun. We now need to conclude this episode, and for this, I'd like to ask you for your top 3 messages on cardioneuroablation.
Take-home messages.
We are still need to understand the importance of autonomic nerve system in clinical bradyarrhythmia, and we still need to understand the real cardiac neuroanatomy, and after that we will be more successful in cardioneuroablation. We understand that CNA is still an experimental strategy, and there are too many unknown questions like best mapping method, best procedural endpoint, and patient selection. And the last one, I think that within 3 or 4 years, we will understand the real mechanism and real effectiveness and, of course, safety of the cardioneuroablation. So we will have a very exciting years in near future.
Thank you so much, Tolga. It was a pleasure having you here today. I learned a lot. Thanks for being here.
Thank you so much. It was my pleasure, David. Bye-bye.
And thank you, everybody, for listening. Stay tuned for the next episode of EHRA CardioTalk. Keep the rhythm.